All right, hello everyone, and thank you for joining for tonight's CE presentation. You guys are in a treat with Dr. Greg Caldwell today as he discusses ocular allergy and hypersensitivity apocalypse, which I think we can all have a lot of experience with right now with allergy season going on. So I'd like to introduce our speaker for tonight. I had the opportunity to meet him at Crew and we got to have dinner together. A super great guy and a world-renowned speaker. So everyone is in for a treat. He is a graduate of Pennsylvania College of Optometry and then completed a one-year residency in primary care and ocular disease at the Eye Institute in Philadelphia, Pennsylvania. He's a fellow of the American Academy of Optometry, a diplomat of the American Board of Optometry, and a member of the Optometric Glaucoma Society. He's also a member of the Optometric Wellness and Nutritional Society. So let's welcome our speaker for tonight, and thank you so much for joining us.
And thanks for having me, and truly an honor and a pleasure to be here tonight. And my job of tonight is to kind of just go over the immune reaction, what happens, kind of tee it up. It's a three-part series, and not to really get in too heavily with treatment, but to really tell what happens in this allergic reaction or this misdirected immune reaction. With that being said, the disclosures are this content was prepared independently by me. You can see a laundry list of people who I speak for, anywhere from Allergan down to Hero, where I've received speaker honorariums, advisory boards, Allergan to Inova, and receive an honorarium for participation. I do work with PharmaNex and get non-salaried financial income from that. And I do sit as the PA medical director for an insurance company. Involve. It's a managed Medicaid program. I do sit as the chairman of diabetes and macular degeneration for the healthcare registries. But really, the most important thing is this content was prepared by me, and I'll present it without any commercial bias. And tonight's pretty easy because I'm not really talking about any products, and I am half owner and optometric education consultants. So again, thank you for the opportunity to be here. Here's my practice. I practice in Duncansville, Pennsylvania. That was a really nice introduction I received. Thank you for doing that. Very kind. And I am a clinician first, then scientist. Some are scientists first, and then they're clinicians. And, I need to simplify things for patients and patient care. Science is great, but it's not good if there isn't any clinical application. So, my lectures are based with science, but basically with a clinical application. So I want to kind of maybe talk about the immune system tonight and how we're seeing it. Now, with that being said, you're going to see when we get into talking about the immune system is that we're going to talk about the innate and then the adaptive side. And it's really the adaptive side that gets dysfunctional that creates the allergies. But, you sit back and, humans and our friends, we're made up of 30 trillion cells. We're kind of an ecosystem, a planet of ourselves. We're a perfect place for bacteria, parasites, and viruses and fungi to live because of the space that we have, the warmth, the rich resources. Some guests are welcome, most are not. So with that being said, we have to have an immune system, but we do have this human microbiome, and you hear about that all the time. I think you're going to be hearing a lot about maybe the ocular microbiome. We hear a lot about the gut microbiome that's out there and how that becomes dysfunctional, and then that can lead to maybe some autoimmune disease and so on and so forth. But bacteria and viruses have a huge advantage over humans when you think about it. They can replicate pretty darn quickly. We have bacteria as one cell that can replicate in 30 minutes. And what did the coronavirus teach us? That viruses can turn into hundreds of viruses in an hour and billions within days. Talk about going viral, right? But if you think about a human, it takes 9 months to replicate, and then the baby needs to mature. So, the body is constantly under invasion. with these viruses and bacteria that can replicate within minutes to hours and days. So we need to have an immune system, and luckily it's sophisticated enough to benefit us. So I want to talk about the human microbiome. Why don't we constantly are being attacking the human cells versus the microbes? We certainly are outnumbered depending on what study you read. Microbes inhabit just about every part of our human body, living on our skin, our gut, our nose, our eye. And then depending on what you read, it says we're outnumbered 10 to 1. Some studies say 1.3 to 1. The key is that, I look at it, whether it's 10 to 1, 5 to 1, 1.3 to 1, we're outnumbered with microorganisms on our body. And I thought this statistic was pretty cool. In a 200-pound adult, that's anywhere from 2 to 3 pounds of bacteria that play a role in our human system. So when you step on that scale tomorrow, you can blame at least 2 to 6 pounds on those bacteria that are living in our body symbiotically with us that are out there. So the gut biome, when we talk about it, I taken some, as you heard, I'm part of the Optometric Wellness Nutritional Society. And I do a little bit of nutrition and trying the vitality and anti-aging. And you can see, here's antioxidants, but the gut biome, there's thousands of species. And the reason why I bring this up is, why isn't our body constantly attacking it? And again, it goes down to that, to that sophisticated immunological system. So this was just more food for thought that was out there before we jump into the immune system. These include not only bacteria, fungus, parasites, and I kind of think about it as we are all professionals here. We've all been exposed to the herpes simplex virus. Had a cold at one time, and that virus kind of lives in our neurons and just kind of hangs out there, and our immune system kind of keeps it at bay. But then at times our immune system becomes weakened, and then we get an infection. And the same thing happens with herpes zoster that's out there. So luckily, again, we have this sophisticated immune system, or this biological system known as an immune system. And I lecture with a pharmacist, quite a few times during the year. She teaches at PCO. It's Dr. Tracy Offerdahl. And she always says, that immune system doesn't like to be tinkered with. It's very prissy, she says. And, and if you think about it, every time we just take a drug, the immune system goes on high alert. And do I need to react, or is this something that's normal that's out there? The immune system is the most complex biological system known to us. It's actually the second, the immune system is second, with the brain being number one when it comes down to sophistication. So brain and immune system that's out there. Now you're going to hear me reference the innate and adaptive immune system quite a bit tonight. And there is a little bit of overlap. You find natural killer cells in the innate immune system. You get some T cells, regulatory T cells in the innate. But what you see out here in the innate, which means you're born with it, you're ready to rock and roll, are your dendritic cells, which we're going to talk about those, your macrophages, your natural killer cells. And then we have the complement system, and we have neutrophils and eosinophils and basophils. That's kind of late phase immune system, or innate immune system, if you want to think of it that way, because when you get trauma, that's the mast cells degranulating. You're getting phospholipase issues and phospholipids. And then you get the dilation of the blood vessels. And then that's kind of late stage innate. When the vessels dilate, then you get the eosinophils, basophils, and neutrophils based upon that. Now, that's kind of you get this invasion of a bacteria or a virus. That's when you get the mast cells, the macrophages, the dendritic cells, the complement system kicking in. And then the dendritic cell literally takes the bacteria into the lymph system to create the immune reaction with those T cells. Remember, that's the lymph side now, and the B cells to create the antibiotics. And then that's the part of the system that creates the allergy, which we'll talk about. So really, I want you to kind of know the innate immune system. These, again, are pretty much your presenting cells. It grabs the pollen in this case, or the bacteria, the mast cells, the natural killer cells. They start to work, but they can only hold the fort down so long. And that's why the dendritic cell takes it over into the adaptive system and creates either the T cell reaction or the antibody reaction or the interferon reaction for the viruses. Now, if you really want to get caught up, I have no financial interest in this series here, but on YouTube, Ninja Nerd Science YouTube, it's like an 8-part series. Just, I love going to it. I lecture in biologics. I need to know how the immune system's working and where these drugs are working. We have 2 new medications, Tepezza and Oxervate, and how they're working there. And then we have our current medications like steroids and antihistamines. So really, it's just kind of neat to watch. And he draws this all out over a series and works on this whiteboard. But right down in here, he's showing this bacteria invasion, and then basically the innate immune system kicking in, and then that's starting to neutralize the bacteria. But then here's what's happening with the blood vessels, creating the blood vessels to become leaky, creating that edema, creating those eosinophils or neutrophils or basophils. And when it's allergy, when you hear us talk about allergy, it's really that eosinophil that kind of comes through in this kind of late phase of the innate immune system, and we'll talk about that. And then over here, he's pointing about how part of like that dendritic cell has grabbed, or part of the macrophage has grabbed that bacteria, puts it on the cell surface, takes it into the lymph system, and then you have T cells and B cells, and all, you can see all these interleukins that we talk about, creating eventually the antibody. And that's the antibody that creates the problem, which then goes, and in a bacteria or in a allergy, that protein of the pollen gets recognized as not being self. Some people it does, some people it doesn't. It creates that IgE that we're going to talk about. And then it goes and plugs into the cell membrane of the mast cell, and then creates that histamine to release. So the innate immune system, this is not really where allergy occurs. It is, because that's kind of like where the mast cells hang out. But the mast cells get sensitized, for lack of a better term, because the adaptive immune system, some type of antigen presenting, whether it's a macrophage or a dendritic cell, grabs that pollen and says, you know what, I don't think you are me, takes it over into the adaptive, and then that whole process of the adaptive immune system, T cells, B cells, all in that lymph system, create the antibodies, usually IgE antibodies, and then that's what plugs into the cell membrane of that mast cell. So then the next time that patient is exposed to that pollen, which kind of classic, I have people from Pennsylvania. I'm from Pennsylvania. They go to like Myrtle Beach in March, April, this time of year to start their golf season, get warmed up because it's starting to warm up here in Pennsylvania. And they'll come in and they'll be like, oh, Doc, how can I have these allergies? I was just down there last year and nothing happened. Well, that's when they became sensitized, right? They went down, the trees were blooming, and they became sensitized. They came back home. They're used to the pollen around here. Go back down a year later, and boom, they have a big allergic reaction because that IgE kicked in and primed those mast cells sitting over there. So the innate system, it's inefficient against billions of combinations. So, let me talk about the innate system a little bit more. It's ready when we're born. It's neutrophils, macrophages, the complement system, dendritic cells. The innate immune system has memorized most of the bacteria, viruses, and foreign invaders. Macrophages can eat, I thought this was kind of neat, about 100 bacteria before they poop out. The neutrophils, they're kind of like suicide bombers. When they just see something, they just go in and explode all their chemicals and just wipe out everything, the host cell and the bacteria. The complement system, if you remember, is the membrane attack complexes. That's part of the innate immune system. This is the quick response. The dendritic cells, they're kind of like the intelligent officers. They destroy invaders, but they start coating themselves with this proteins. It's all about the protein that's out there that's not self, and takes it into that lymph system and starts that. It's ineffective against the billions of combinations of mutations that are out there. So that's what you hear when things mutate. And that basically is the protein structure that, hey, I recognize that protein structure, but not that one. The innate immune system can't attack the new structure. But the dendritic cell can say, hey, guess what? I can take you into the lymph system, and I'm going to take you into the B cell and T cell, and it's going to learn with those antibodies, because of those structures, those tips of those antibodies, those Y structures we always talk about, can change their 3D shape. So the next time it comes into contact, it can have a reaction with it. So really, really cool. This really sophisticated, again, second to the brain on how it works. Now, the adaptive immune system, it's slow to deploy, but when it hits, it creates a huge punch, right? And we learned that through the coronavirus, with some patients getting that cytokine storm, and that's what was really creating some of the really sickness and death that was out there when that adaptive immune system, that virus, that coronavirus, in those, in a sense, oxidatively stressed people, people with diabetes and high blood pressure, maybe poor diets, didn't really have maybe the most abundant immune system, then that virus would replicate, but the adaptive would kick in, but there'd be so much virus, and then you would have this cytokine storm that's out there. But it's slow because it takes time to find. So that dendritic cell is bringing in that new protein. It's looking for that T helper cell. Then it has to clone itself. And then once it clones itself, it has to talk to the B cell. But man, when it does, you can pack one heck of a punch by getting the, in a sense, a virus interferons, or you can get antibodies, which are super effective and deadly against our enemies. But again, it just takes time. The adaptive immune system's awesome, but it's just slow to react. Then what happens, our immune system just kind of has to calm down. It basically starts killing off the B cells and the T cells that were just created. It's part of that homeostasis that's out there, that balance. However, there are some T cells and some B cells that turn into those memory cells that are out there. So you really can't talk about allergies unless you kind of talk a little bit about the immune system. You have to talk about the innate. You have to talk about the adaptive. I wanted to just touch base here. You see what's happening. When I went to school, we always talked about T helper 1, T helper 2, but you can see here that there's many T helper cells now being found in our immune system. And that's part of that CD4 count that you hear. So I just picked on T helper 9 here because I could talk about all of these. We're familiar, I think, with T helper 1, T helper 2. T helper 9 is a subgroup. It's a CD4. You're differentiating from these different cells. But what happens is you have this naive T cell, and then it gets reactive within. You can see down here in the graph, you can see it's interleukin 2, and you got this transforming growth factor beta, and then it starts to turn into T helper 9. And then depending on what other now chronic inflammation or what other cytokines are out there, it turns this T helper cell into something that maybe can turn into allergies or an overreaction that's out there. Now, when it comes to the immune system recognizing self and not self, it's all about the proteins, right? Proteins are the building blocks of life. Proteins have billions of shapes, 3D puzzles, billions of combinations of our enemies can use to construct, meaning bacteria, fungus, and anything that really invades. Proteins are the language of the micro world, right? They don't have eyes or ears, these cells, but they talk and they rub up against each other, constantly looking for proteins, and that's how they talk. And whenever they don't recognize the certain proteins, a neutrophil will explode, or the dendritic cell will grab it and take it over to the lymph nodes. So really, it's all about the proteins that's out there. So in a normal adaptive immune response, you have a pathogen that comes into the body. And then when I say it could be pathogen, it could be bacteria. Let's just say too, we talk about antigen, let's just call it an allergy. These are all proteins. So the protein has entered in your dendritic cell, your antigen presenting cell, we always hear that, grabs a hold of it. And then you start this whole process. Now you can tell that I'm in the adaptive immune system, right? Because you can see I'm talking about T cells, B cells, plasma cells. You get the antibodies. It could be IgG, IgA, IgM. You hear about IgM and IgG in Lyme disease. When we talk about allergies, it's usually IgE, but these antibodies then go over and attack the pathogen and eliminate it in different ways. The IgG, A, M, and E have different ways to eliminate we don't have to get into that tonight, but they have different ways to eliminate the pathogen. And the pathogen is then eliminated. Hypersensitivity versus an immune dysfunction is an exaggerated or inappropriate response against the antigen or allergen. So that's the key. Hypersensitivity are immune responses that are exaggerated or inappropriate. I think it gets confused because we talk about immune dysfunction a ton. We talk about it with dry eye, chronic inflammation, all the interleukins and all the medications that we use. We have a new medication out there, Tepezza, because we get an upregulation of certain receptors in the orbit, and then that creates the reaction. And the same thing with macular degeneration. Like macular degeneration, in a sense, is immune dysfunction down here in Brooks membrane, and that's why we check for these alleles that happen, these SNPs, these single nucleotide polymorphisms. And you can see the arms in the complement factor H and complement factor 3. This person is low, this one's high and moderate. And we're talking again right here with the complement system in macular degeneration. And you can see here complement factor H and arms, that's out there. And this talks about the different zinc. But down here, you can see that mutations have occurred. And what has happened is the complement system is not recognizing certain proteins, and the complement system, and you get drusen building up, or you get some dead cells building up, and they look at the protein and it doesn't recognize it, and the complement system starts to become dysfunctional. So the reason why I point this out, you're going to be hearing some pretty cool medications coming out this year for geographic atrophy that talk about complement factor C3 and C5 that are out there. But that's just kind of like, is it hypersensitivity, or is there just a dysfunctional immune system going on? Again, thyroid, macular degeneration, dry eye, or is it like allergy where we're having a problem with mast cell degranulation to these proteins? So an allergy is a result of a beneficial immune system that has gone awry. A hypersensitivity is the same thing. We were taught type 1, type 2, type 3, type 4. Well, you could see type 3 is what we just talked about in a sense with macular degeneration. We're going to talk about type 1 and type 4 because that's true ocular allergy that's out there. So allergy is hypersensitivity. True ocular allergy is type 1 and type 4. And my pearl of tonight is ocular allergy is a dysfunction of the adaptive immune system. You get allergic conjunctivitis where IgE has prepared the mast cell, and that's your true allergic conjunctivitis. And your contact dermatitis has nothing to do with the adaptive immune, has nothing to do with the IgE part of the adaptive immune system. It was that other part where we talked about CD4 and CD8s, where they start now attacking, and that's your contact dermatitis or your type 4 that's out there. So type 1 hypersensitivity, it's immediate, it's a bug bite. It could be when you take a medication, the worst thing that can happen, right? You give someone a medication and an anaphylactic shock. They take the medication the first time, no problem, because the immune systems had to form that IgE. But now the body has made IgE antibodies, plug them into all more than just the mast cell, but we always pick on the mast cell. And the next time they take that medication, bam, you get this kind of cytokine storm that occurs in histamine as a cytokine, right? And all the other things that happen, and it's all due to IgE. So that IgE response, we talk about it as an allergic reaction. You can see here, this is the end stage we talked about, that adaptive immune system. Now you got these IgEs plugged in all over the body and in the eye, the conjunctiva, for that allergic reaction, ready now for that antigen to happen. So again, we need that adaptive, we need that pollen to go, it's over here, sorry, I switched them around. We need that pollen to go into that lymph system, create that IgE, and then really go out and start priming that innate immune system to be ready to attack the next time that pollen comes in. And that's what's really happening. I'll go through real quick. As you can see here, this is immediate reaction. And next time that pollen comes in, when you have an IgM or an IgE response, we see that in lupus. We see that in myasthenia gravis. I tried to make things relevant here, where your body in myasthenia gravis attacks those receptors, and then you don't have that acetylcholine beating on those receptors, and you create that. The same thing that what happens in thyroid eye disease, you get a production of that anti-thyrotropin receptor, that it's an IG1 subclass, and then you get in the orbit of the eye, you get thyroid eye disease. So you could see the attack that occurs on one's own body that's out there. And this was just really neat, showing how thyroid eye disease and these thyroid receptors, you could see it starts with one of these dendritic cells. You could see this is talking about vitamin D maybe being linked to it, but we could see the T helper cells, the basically coming up, hitting now into creating the antibodies to attack the thyroid, but the same thing can happen in our orbit. Then we have our hypersensitivity, our delayed. This is type 3. This is that immune complex. This is after exposure to the antigen, the individual's immune system responds by creating antibodies. It could be 4 to 10 days. This is kind of that macular degeneration. Kind of think of macular degeneration. I'm telling you, there's some really cool stuff coming out. Do your homework, study about the immune complex, this type 3 that happens. This is what happens a little bit in lupus, and this is also what happens to those drusen in macular degeneration, where you get this whole antibody production. These complexes activate the complement system that's out there, that membrane attack complex. If you remember, you get these complexes, but now the immune system, the complement system, attacks these. So these immune complexes, you can see the antibodies and the antigen, then it gets stuck in tissue, and then your complement system says, "Hey, I don't like what's going on here. Get this out of here," and it starts to attack it through the complement system. And that's what's happening here again in macular degeneration. Now back to what we're talking about tonight, this this, ocular allergy. Ocular allergy is immediate with that histamine release. That's your allergic conjunctivitis. But what about these patients that get contact dermatitis? Well, it's actually a Langerhans cell, which is a very special type of macrophage or dendritic cell. It's an antigen presenting cell of the body, grabs that protein and then takes it into the lymph system. But instead of this antibody reaction, we get this CD4 and CD8, these kind of natural killer cell type of reaction with the T cell mediated. It doesn't go through that whole where T cells and B cells, plasma cells, antibodies. You get this whole other reaction from the T cells that come down and create this hypersensitivity or this inflammatory reaction. Now, remember I keep saying it's about the proteins, but when you think about like poison ivy or nickel, those really aren't proteins, but what happens is those molecules, or what they call haptens, bind to a carrier protein, and now this hapten protein type of foreign antigen now gets recognized, gets grabbed by those Langerhans cells, those specialized macrophages and dendritic cells, and then creates those T helper, those CD4, CD8 cells, not the T helper, but those CD4, CD8, and create the immune reaction. And that's why it's delayed, right? Someone goes to the Caribbean, they buy this ring. Hey, this is a really cool ring. Let's remember this trip. Oh, it's only $20, but it's a cool ring. And then 6 months later, take the ring off and like, wow, what's going on here? The nickel becomes a hapten, but it's not this antibody and mast cell and all this other stuff. It's this T cell, CD4, this cell mediated is what you hear it recognized when you read the literature. So allergic contact dermatitis is one of the most frequent inflammatory diseases, and it's characterized by redness in vesicles, scaling, and dryness. It's elicited upon contact with non-protein, right? I keep saying it's about protein. Well, it is, because these haptens then interact with the protein, and then we move into this mediated hapten cell specific T cell reaction. You get these CD4, CD8s. It's not about the antibodies on this side. And this leads to apoptosis of the keratocytes, recruitment of inflammatory cells, and a development of your clinical symptoms. I just thought that this was just a really cool slide here, just kind of reminding us that we have the capillary and the arterial. This is the capillary bed here. We have where did it go? We have the capillary side of the arterial bed. We have the venous side. We have now the venule, the artery, the capillary bed. This is your interstitial fluid. So we have all these macrophages and dendritic cells and mast cells. But right next door, we have the lymph system, and just how integrated and complicated and sophisticated our body really is. In allergic dermatitis, experimental studies have demonstrated in normal contact hypersensitivity CD8 cells and T1 cells that are out there. The key for a contact dermatitis, it's really not that antibody broken side. It's the CD8 or CD4 and CD8 cells that are out there. So when we classify ocular allergy, we have allergic conjunctivitis, which could be seasonal, and that's what's happening right now in Pennsylvania. And I bring out my cell phone a couple times during the day and I show people, look, it's trees right now. Then what will happen in a few months, the grass. And then what will happen in August and September is weeds. So it's usually trees, grass, and then weeds is what happens. So that's your allergic conjunctivitis or your type 1. All of these are type 1. There's atopic, vernal. GPC is type 1 and type 4, and your contact dermatitis is type 4 that's out there. So let me just go through a couple cases. My job tonight was kind of tee this up for it's a 3-part series, kind of learn about the immune system so that you can know where these medications work. And I feel bad because I couldn't get the video downloaded from my website from work. I had a guy come in. He was classic allergic, itchy, rubbing his eyes, but asymmetric. He was asymmetric. And that means he had the mast cells degranulate in one eye, the vasodilation, the eosinophils coming through those leaky blood vessels. That eye needs a steroid. The other eye wasn't so bad. A little bit of itch, a little bit of redness. Probably could get away with a little bit of antihistamine type of reaction or treatment over there. So this is a 32-year-old man. You know, my eyes are so bad, I want to claw them out. I went golfing today. It's May. He's rubbing. He feels like it's making it worse. And when you look, you can see that when you flip his eyelid, he's got vasodilation. He's got redness. He's got papillae. He's got bulbar injection. This happened last year or happened 2 years ago, but not as bad as this. So he has seasonal allergic conjunctivitis. Now, seasonal occurs spring, fall, and that's why these apps are helpful. Grass, tree pollen, weeds. Perennial are these patients that come in, right? And they have allergies all year long, kind of low grade. And you say, you know, what do you have at home? They go, well, yeah, I got 12 cats. Well, you're probably allergic to the cats, but they're not going to get rid of the kitty cats, right? And so we kind of have to deal with this kind of low grade, smoldering perennial. It's usually animal dander, could be dust mites, molds, grass, and they usually have a history of maybe some allergies that are out there. The signs and symptoms of allergic conjunctivitis: itchiness, redness, blurring, excessive tearing. Then you start getting that white stringy mucus discharge. Perennial, it's all kind of the same thing, just kind of a little bit low grade that's out there. The non-pharmacological approach, because I thought that would be important because you're going to be hearing the pharmacological side coming up. Pet control using HEPA filters, cold compresses, lubricating eye drops. This one was taught to me by an allergist, and I think it's very, very important. Basically, wash your hair before going to bed. Today, I went golfing. It was one of the first warm days in Pennsylvania. Went out, went golfing, and my hair was in all this tree pollen. So luckily I had this webinar tonight, so I was able to come home, shower, and get all that tree pollen. So when I went to bed at night, I wasn't putting my face in all that pollen and creating that immune reaction. There's, you can see that this is the pharmacological approach, but you're going to be hearing about that as this series goes on. So really, I want to focus on these last few minutes here. You know, what is happening? It will help you with diagnosis, management, treatment, and how these pharmaceuticals work. The ocular allergy is mainly that we see is type 1. That's our allergic conjunctivitis. And then we do see a lot of type 4 in your contact dermatitis. But when you see a type 1, there's a sensitizing phase. There's an activation phase, and then there's a late allergic response that occurs. So again, you have, this is being the conjunctival epithelium, and in that interstitial fluid, in that really cool picture that I showed you, you have capillaries, and you have the arterial side and the venule side, and you have lymph channels and lymph cells and mast cells and, you know, everything, that innate system. So if you remember, in this asymptomatic allergic sensitizing phase, the antigen comes in this case, the pollen, you get a macrophage that recognizes it. Over in that adaptive immune system, T cells, B cells, plasma cells, boom, there are your antigens. Those antigens now go in and plug into the mast cells now of the conjunctiva in that interstitial fluid or interstitial space. And now the next time, maybe a year later, this antigen comes in, this pollen, this protein, hits this now primed and ready to go mast cell, and boom, it talks and spits out histamine and your eosinophilic chemotoxic factor A. So your eosinophils, you get heparin, and then that starts to work on the blood vessels, right? Now it says, hey, look, it keeps spewing out cytokines, chemokines, and now you start getting vasodilation, the phospholipid, arachidonic acid, leukotrienes, recruiting white blood cells. In this case, eosinophils, but a few basophils and neutrophils, and then you get the redness that occurs. And this late phase works on the blood vessels. When you're to late phase, my clinical pearl is you probably need something stronger than an antihistamine. That's why I like recognizing dilation, maybe a steroid for just a few weeks, maybe a steroid for a few days, because the basophils, the eosinophils are coming out, and then they have all of these enzymes and release more histamines and leukotrienes and creates the immune reaction, which now creates that tissue damage and the edema that's out there. So here's my guy, 28-year-old man, flew to North Myrtle Beach to go golfing. His eyes became itchy. He rubbed them. He was there last year. Nothing happened. I said, hey, do me a favor, because I've been to Myrtle Beach before about that time of year. Go out and see if you can find a dark colored car. Take a picture for me. And it just rained the night before, or this was some dew on the car or something, but it's all dry. This is the pollen from the tree pollen. These pine trees just bloom. I've been down there, and it just sometimes it blows and it just looks like a yellow haze. And this is that tree pollen that it took last year, the year before, to sensitize him. He goes back this year. The immune system with those IgE has primed them up. So under the slit lamp, you can get some really good swelling that can occur, a lot of edema that can occur. We're not going to worry about the treatment. You're going to get plenty of treatment coming up. My job is to kind of tee it up to show you what happens. In that second exposure, again, that mast cell is now been recognized. You got these preformed, and you have this type of reaction. Is this type 1 or is this type 4? You could see right here what happened is you got this great explosion, immediate IgE type 1 reaction that has occurred. It's part of the adaptive immune system that produced those IgEs and primed those mast cells. This one I like. This is a 6-year-old boy, came in. His eyes are red and itchy again. It's April. It's May 10th. He started about the beginning of April. He rubs them all year round. He's already using Pataday. This was prescribed by his pediatrician, but he's still rubbing them. He's getting this mucus discharge. Let's take a look. And so here's our boy. And I look at him and I go, man, he looks pretty darn good. I'm not sure what's going on, but we have to take a closer look. When I take a closer look, you can see right at his limbus, he's kind of got these little white blood cells. He's already through that first part of that type 1, right? The histamine has released, it's done everything. He's now has leaky blood vessels. You can see, I'm going to zoom in here, you can see the eosinophils that are building up into his eye. So he still has the itch, he just doesn't have that explosion of redness and swelling. Now he's got these Tranthus Horner dots, I believe is what we call them, or these eosinophils that have built up at his limbal area, creating his reaction. So this is the part of the reaction that we're talking about with this child. He has leaky blood vessels, and you're getting the basophils and the eosinophils, and the itch is now coming because of these enzymes and the histamine that's being liberated from the basophil and the eosinophil, and that have, in a sense, creating this tissue damage, that this high exposure of eosinophils typically in an allergic reaction. And that's why when we talk about vernal conjunctivitis, ages 3 through 25, males versus females, those large papillae, Tranthus Horner dots, a well demarcated sterile ulcer or shield ulcer. It's type 1 with early and late phase reaction, and children generally outgrow them. And that's what our child was here. Advised them to wash his hair before going to bed, some tears. But because of the white blood cells, we need to now start thinking steroid treatment. And again, this is a 3-part series. I'm just trying to tee it up. Here's one I thought was pretty interesting. A 25-year-old man, his eyes are red, itchy all year long. So now we're talking a little bit of perennial. He does cold compresses and some artificial tears, some pad a day. He works with the public. He's a stockbroker. And he's like, my eyes are always red. And people are asking me about that. He also has asthma and inhalers. And let's take a look. You can see here, hey, I'd like to invest your money for you. And people are going, should I do that? He says, what's this guy doing with my money? And you can see here, he's got redness. He's got maybe a little bit of some cellular infiltration right here on the cornea. You could see he's got a little bit of dermatitis out here on the skin. This is beyond, like antihistamines and maybe some mild immunomodulators. You need to reach out for a steroid at this time. And so we decided to put this gentleman on a steroid. And you can see, I'm not sure if I would invest some money up here at this picture, but I certainly wouldn't mind investing money down here. Crime must fit the punishment, as we always say. And I have no problem, with this gentleman here. And he's an atopic keratoconjunctivitis patient that's out there. Here's a 64-year-old woman diagnosed with bacterial conjunctivitis 8 days ago. She was using tobramycin 4 times a day, appeared to be worsening. So her primary care doc said, hey, why don't you bump that up to every 2 hours? Decided to come in for a second opinion. And you can see this eye looks great. The eye looks wonderful. Doesn't really look like bacterial conjunctivitis. You can see she's having a contact dermatitis. Nothing to do with IgE. It's all those CD4, CD8 reactions in the skin. And that's why the eye is usually pretty white and quiet with these, because it's those Langerhans cells, which are very specific dendritic cells. And what has happened is now you're getting that CD4, CD8 reaction. I told her to use it every hour with the no, I'm just kidding about the tobramycin. I told her to stop it. We put her on some steroid creams. And you could see 6 days later, by taking away the antigen, which in this case was the tobramycin or maybe some inactive product in it, you can see she cleared up nicely. So type 4 hypersensitivities, they occur in hours, days, months. It's usually coming in contact with, hence the name, contact dermatitis, some topical medication, jewelry, nail polish. You do get itching, redness. You get superficial skin changes, lots of causes that are out there. And I'm going to show you multiple cases here. This is a patient, in for their pink eye, contracted from her granddaughter. It just won't clear up. Started 3 weeks ago, worsening, now stable. And you look at this patient and she thinks that she has pink eye bilateral from her granddaughter, but it's probably the alpha-GAN P creating this reaction. We see it all the time with those alpha agonists that are out there. So we stop the alpha agonists and things clear up. Now, is that type 1? Because ocular allergy is truly just type 1 or type 4. So this here is a type 4 reaction. Again, that delayed, we hear cell mediated, that's those T cells, CD4, CD8s that are in the skin creating that type of reaction that's out there. And again, I get them all the time, people coming in. You could see this reaction here. This is another brimonidine. You stop the medication, the wrinkles get better, the hair gets better. They come in, they're scared. They go to bed the night before, everything looks good. What happened? What's going on? They come right in, and you can see you just stop the antigen and it goes away. Now, type 1, type 4 are true ocular allergies. Contact lens induced, this is why GPC is a bear. GPC is a bear because conjunctival biopsies with GPC have resulted in total number of mast cells were higher. Dendritic cells did not really differ, right? So it's not really taking it to that lymph system, but they're able to get eosinophilic infiltration. You've got plasma cells going on. You have the CD4, CD8. It's a type 1 and type 4 reaction. And that's why contact lens induced GPC is such a bear to treat. Increased number of connective tissue, mast cells, eosinophils, plasma cells, T cells. It's a complicated condition. You're having eosinophils and CD8, and it's just an allergy to the contact lens, right? A material that's there, or the solution, or various types of signals that can create that. So this is a 37-year-old woman previously treated for contact lens overwear, Maxitrol, on and off. She was told she has a sterile ulcer, so she wanted to come in for another opinion. It's been happening. This is the third time this year. Here's her reaction that's going on in her cornea. Again, you can see the white blood cells, the eosinophils that are kicking in. Why is it so recurrent? When you flip her eyelid, she's got a really bad GPC. We got to clear up the GPC. This type 1, type 4 reaction that's going on, that was the other eye. Type 4, type 3, type 1 and type 4 reaction that's happening to this patient. And, basically I tell them, look, you're going to be out of contact lenses for a year, but we've got some good treatments. You only be out of contact lenses for maybe 3 to 6 months as we go through and we treat you. I see we have a couple minutes here before I have to kind of wrap up this part, but let me go through and make sure I hit giant papillary conjunctivitis. And I think I want to talk about flectenules that's out there. Let's see. Yep, flectenules. This is a confusing one. Is this a hypersensitivity? Is this an immune dysfunction? Is it ocular microbe, right? Is it maybe the Staph aureus, the Staph epidermidis? Have they mutated and our body's not recognizing it? So we talked about all the true hypersensitivities that are out there, but this 14-year-old boy with my eye red, irritated, started about 10 days ago, tried some artificial tears, and you can see this accumulation again of white blood cells. That's what a flectenule is on the eye. It could be conjunctival, they could be cornea. You have to rule out, some of the bad things that can be happening, like TB. It could be ocular rosacea. In children, most common is Staphylococcus aureus, maybe a mutated version, and our body is just, killing it off, and those proteins aren't recognized, and then you're having this immune reaction that's out there. So, I just thought this was really kind of cool. In the next minute here, the first line is our mucus. Then we get down into the phagocytosis, and that's the innate. But really what happens is you get that pollen down in here. It creates that lymphatic reaction, and then it goes back up here, and it gets at this level of the skin, everything primed, ready for that next time that pollen comes in. And remember that eosinophils and neutrophils are in the bone. We get T cells and B cells in the lymph system. I've been working in my yard. This just happened this week. And you can see she's been working in her yard for 2 weeks. And now with all the tree pollen, she's busting out. But this is going to need something that needs a steroid. And you can see add crime fits the punishment. And she slowly clears up over time when what I want to point out, not only does she have the histamine release, but she's got those eosinophils and basophils happening because of the vasodilation. I see it's 9:25. I was supposed to end. Just give me 1 minute. I'll be really sensitive to that. Here's another contact dermatitis. This patient came in recently. And again, you stop the offending agent. You can see it's a CD4, CD8 mediated reaction. This was a friend on Facebook. She's like, can someone help me? I can't tell what's going on. She's a friend of industry. And I called her up and I said, hey, look, what are you using? Oh, really nothing. You're using something. And eventually she's like, Avenova? I said, yeah, why don't you stop it? And she cleared up nicely. This is a gentleman, he's trying to figure out how to get some eyelashes on. He wanted to do a one-eye trial of Lash Boost. It's one of those, chemicals out there, which is nothing more than bimatoprost, and a weak solution you can see is contact dermatitis. My friend came up to me and said, look, I'm putting this antibiotic on my arm. You think there's a better one I could use? I said, yeah, why don't you stop whatever you're using? You're having a contact dermatitis. And this was a immune reaction. It didn't clear up through steroids. This was a conjunctival flectenule from Lyme disease. So other people were trying to treat him. It was an immune reaction, but an immune reaction. He had Lyme disease. Again, remember, sometimes these are tied into like TB. So sometimes if it doesn't respond, think of those other, I don't always think of zebras. I think of the zebras whenever the horses don't work, in this case, the steroids. So I just want to say, we talked about the immune system, but don't forget about the neuroimmune system. It's a whole separate part. It's in our brain and in our retina, and that's the microglia that's out there. They're the guardians of our neurons. And that's when you hear about neurodegenerative diseases like Alzheimer's. Chronic inflammation is due to microglia, which are special macrophages. And with that being said, I want to thank everyone for being here.